All right, you guys, I'm going to start the introduction of our next speaker. Again, I appreciate you coming back in the room, but I'd appreciate it way more if you could please be quiet. Bruce, I'm going to put you in the hallway. Okay, thank you. Okay, next I'm going to introduce Jamie Lowy. He received his Master's of Science in Physical Therapy in 1998 from the University of the Pacific in Stockton, California. He's worked in home health since 2000 as a field clinician, preceptor, and clinical manager. In 2016, he started training in the chronic or persistent pain management with the goal of expanding the role of PTs in home health to address issues on pain, incorporating best practice strategies as evidenced in the latest pain science research. This culminated in co-authoring the Pain Management in Home Health Practice resource with fellow San Diego Pain Summit attendee, volunteer, and presenter Keith Waldron for the American Physical Therapy Home Health section. Jamie has recently taken on a new role in the primary care setting in addressing broader population health needs for low-income and homeless community in the realm of persistent pain management that utilizes an integrated approach between physiotherapy, primary care physicians, and behavioral health clinicians. Jamie presents to local healthcare practitioners on pain management and has presented at the APTA Combined Sections meetings. In addition to pain science, Jamie has also worked to introduce incontinence management and pelvic health PT into his home health and primary care clinic practice, owing much of this to the mentorship of Dr. Sandy Hilton and Sarah Haig. I didn't know that was in there. I didn't. He is an avid martial artist and has most recently been training in Aikido with his teen son. So I give you Jamie.
Thank you so much. I'm as nervous as shit right now. So I thought I would get into the right mode by identifying my dress code. I'm normally a fairly casual clinician, so today I opted to go with my vest unbuttoned, if you had any questions about that. So I have one small addendum to my bio, and that is this past Friday, I notified the home health agency that I've been working for that I will be ending my services with them so I can commit myself full-time to the clinic I'll be talking about with you folks today. So one of the things that I wanted to kind of tie in is that, and I was talking to Neil O'Connell about this on the break, is that this particular weekend seems like all of our themes are beginning to mesh in. And in particular, when we talk about some of the stuff that Ben was alluding to in his presentation, and then coming right through our wonderful pain patients. This is going to be messy. My work with the homeless is one of the most difficult endeavors I've ever voluntarily stepped into, and I'm voluntarily stepping deeper and deeper into it every day and every week. Now, because this is a very deep and messy subject, I am going to do my best to add a little flair into it. This will also be our first attempt at using some polling questions. So when those come up, you'll have a chance to weigh in on some of the options I provided you. So I threw these in because Rajam has some very nice learning objectives, but I felt that for my particular topic, I wanted to get a little bit deeper into what I hope you guys took from this in the now 42 and a half minutes I have left. And that is to really understand when we start talking about these models or these frameworks, biopsychosocial, whatever it is, I've found that this particular population is truly the embodiment of those ideas. Because in no other population have I worked with are these issues so evident. As I was writing things up, I played some music from my teenhood, and I remembered I had this album, I played it over and over and over again. And it was in my head, this chorus. And I had to play it just to get it right when I was finishing things up. And I want you to just kind of, if you know this song, you can play it in your head. I'm not going to judge. If you don't know it, I can play it for you later. But it's the African sound and the idea of wandering, finding maybe some peace somewhere, and then moving on again. So here's how I'll kind of start things off, though. Ooh, that was kind of loud. About me, where I live. This is Stockton, California. If we start right down here, 7 hours and 11 minutes later, if we skipped Los Angeles, you'd arrive where I work. I actually live a little bit further east of the town in a little farming community. So if you want to look it up, I'd be flattered. But here's some little factoids about Stockton and where I've chosen to reside and pretty much call home, having grown up in Oregon and lived on the East Coast and spent some time in Europe. And I don't think this is necessarily a unique situation, other than the fact that it happened at a time in California when we were thinking, this great world is never going to give us anything bad. And then it did. Of note, in just the last couple of years, the population of people experiencing homelessness in my community has more than doubled. And in that time, we have not added any more shelter beds for them. In fact, if you want to get more detail about the delightful place where I live, it made Forbes magazine as the most miserable city to live in 2009.
Only New York City has a higher.
Right? But even New York City rated as a better place to live than Stockton. Love my home. I work for what's called a federally qualified health clinic. What that means is we receive grant funding. We are eligible to bill through Medicare and Medicaid. We also have the option to provide services for members in the community that do not have health insurance, and we get subsidized to provide those services for a very low cash sliding fee scale. So this is the main clinic where I've worked. It is in downtown Stockton. Let me back up a second. This picture here is taken about 2 blocks down from the clinic, just for excitement's sake. This nice little house on the left is our house for our homeless population to receive services for substance use. There are counselors on site. We have doctors, nurse practitioners on site. And from there, it may be a transition for them to finally get maybe some shelter and a bed and maybe some extra support to figure out how to move on from there. Here's a little bit more about us. I won't read the whole thing because I'm hungry. I have not eaten today except for a quarter bag of gummy bears. I'm hoping that does not haunt me in about 10 minutes. What we see are sometimes some of the people on the street corners, maybe they've got their signs, maybe we see them sleeping on a bench or in a doorway, maybe we see them relieving themselves out in public because they've got nowhere else to use the bathroom. So there's a much broader population here that we're not always aware of. They're kind of the invisible homeless, not just the sheltered in the defined sheltered areas. These are people who are maybe finding a quiet spot to park their car, or they have a little trailer, or they found temporary refuge with a friend or a relative for a week. Maybe they can afford to be in a hotel for a little bit, and we really never see these people. And where this is going is that it's now becoming part of the conversation. And one of the reasons why it's becoming part of the conversation is due to this delightful state. In California, our homeless population has gone up probably in the ballpark of about 3% or so in just the last year. And one of the defining reasons for that is the cost to live here is too expensive, and that employment is not keeping up with our ability to live in places where we can also work. But what if you don't have the capacity to work for something that may not always be in your direct control? And this is where we're going with this as I give you more exciting background on the homeless crisis, as I like to call it. So about 600,000 people, some numbers have been a little higher, some a little lower, every night in the US are not in a stable home or a stable residence. US-wise, in the course of a year, they estimate it's about 3.5 million are cycling in and out of homelessness. Being a parent, this kind of chokes me up a little bit. My son, who's adopted, sometimes wonders what would happen if he didn't have his mom and dad. Would he end up on the streets? So there are real fears that are going on even in kids that have a stable housing, but they may know someone in their school or through social media that is talking about this experience, and it's kind of driving a lot of this anxiety. Now, just to the north are delightful neighbors who I love, and this is a shout out to you Canadians in the audience. You may get a twirl just for that. So, my little math point, and no one's going to be tested on this one. If you need to correct me on it, though, I'm cool with that. But 300,000 approximately estimated homeless population in Canada. 3 to 3.5 million in the US. 1/10. Well, we're also 10 times larger than the population of Canada. So the numbers, ratio-wise, are very close in equivalence. And the interesting thing about this is that when we talk about socialized medicine, we talk about some access to care, it's not because these people cannot access the care. It is there for them. There is something else driving this condition. For the US, here's just some numbers. If you need some graphs, I wanted to get some visuals here besides me. So this just kind of gives you a little breakdown. This was interesting because this is broken down by proportion of our overall US population. And it took me a while to look at the graph and realize what they were actually saying because I was confused at it. And then it's kind of giving a rough breakdown. But I wasn't happy with that on Friday night. So I added this from some of the other studies out there, data collectors, about where we are in the homeless population. Oh, you know, I've been spending too much time over here. I'm going to walk over here now. You guys are not getting the full appreciated view here, right? Thank you. All right. So I wanted to call attention to this because I decided to be a bit of a envelope pusher yesterday. Not because I felt it was something that I just wanted to do a kind of a, what the kids call it? A dick move. But we are talking about some very poignant social issues. And unless we're going to encompass all of the social issues that make up a lot of these problems that we're identifying, we really can't have a substantive conversation about what are we really going to do about it. So Stockton has a very gentrified population. And in my home health job, I spent a lot of time going into these smaller pocket neighborhoods to provide my care. And it's always interesting when I drive up, being this somewhat well-kept looking, now middle-aged white guy, walking out of his car in a neighborhood that I clearly don't belong in as far as my residence. And there's always suspicion at first, because usually when someone with my presentation comes into that neighborhood, it's to buy drugs, buy a person, or I'm a cop. So I come in, and they see the care bag that I come in with, and the moment they know that I'm there to bring something to them, there's a shift. I've even had people say, you know, I wouldn't park your car there. Why don't you bring it over here into our driveway, and we'll watch it for you? Because you're to take care of Grandma. And that's going to play into what brought me into the clinic. Oh, this is good too. Just so you want to get demographic status here, or stats. These folks kind of tell you how they're managing their pain. And again, some of the issues that we kind of get into is we do a really nice job of collecting data on people that we're attempting to provide service to. What I liked about this study that was done in, I think, 2011, is that they also interviewed the physicians about what their attitudes were about the care they were delivering and what they thought were the issues as to why there were more health problems, and attempted to compare that to what the homeless people were saying. And what they found was they had 61 physicians respond out of over 150 that they attempted to interview, whereas they pretty much got all of the homeless folks to give them some feedback. I think that speaks volumes to either our inability to speak to their problems because we haven't asked them, or our level of comfort in our dealing with problems that make us feel very, very uncomfortable. And that's why I'm like this. Don't worry, this is not the splash zone. This is not SeaWorld. You guys are safe. Because in order for me to feel that I'm effective in my job, I also have to be willing to be a bit more vulnerable, a bit more uncomfortable, and be able to accept that my point of view is only the point of view from my perspective on the world, and is no way going to dictate what the person in front of me should be doing with their life. And far too often, as healthcare professionals, we tend to impose that bias on people, sometimes very subtly. And if we're not aware of those, we'll get to this in a second, if we're not aware of those biases, then that's a problem. Okay, real quick, because I'm looking at my timer and going, oh my God, I could do all this all day. Right, Keith? Meldrum? All day. Okay. This is cool. All right, let's kind of, most of you, about half the room or so, it's kind of what you thought, right? These numbers do not shock you. And so I think that kind of speaks to, again, we are aware there's a problem. It's in the news. There's some articles about it. We're becoming more sensitive to these ideas. So when I came into the idea that I'm going to start working with people who are in pain, who are disadvantaged socially, low income, they might be homeless. I also treat a lot of individuals who are undocumented workers, and they have the fear of if they don't do their job the way that they are being told to do their job, they'll get ratted on to the immigration authorities and away they go. So what I found was that there was a large number of individuals who had pain issues, but they also had a lot of other chronic medical problems. So that got me curious. We kind of broke down these a little bit. These are from some variety of studies, and it began to make me think about the person who's got maybe hypertension, but they're sleeping out. Someone steals their pills, which is pretty common. And they also have maybe some back pain. And we know that someone in a kind of chronic state of stress is going to impact their other systems. Blood pressure issues may then become a bigger problem for them because their pain is not controlled well, but neither is their blood pressure, because all the things they need to control their blood pressure have also been taken away from them. So now we're talking about not just a pain crisis, but an actual chronic disease crisis. A system, we talked about disease versus illness. Well, now their cardiovascular system is in jeopardy. So when we look at things like mortality, there are rates of mortality that are far in excess over the general population. And even between those who are unsheltered versus sheltered, the rates are significantly different. Just this one looked at 10 times and 3 times, just depending whether they were in a shelter or not a shelter. And look at this. I just turned 50 last month. So I'm kind of in that age range where my mortality is now kind of hitting that point where it could potentially be my end of time if I was living on the streets. All right, we're going to jump in this one a little bit too, because I got to move on with this. Okay, let me just kind of see you. Oh, good. This is my favorite answer. Don't let me down. I'm not sure where this is going to go. It's very exciting. You know what? I'm not going to look at the math. Because that just makes my brain hurt more. Okay. But I think, how you guys are answering is again, it's interesting because, most of you, meaning more than 50%, felt that pain leads to homelessness. Hello. And shockingly, you're not too far off. This was a study in a project done in London where they actually went into a variety of shelters and programs and began doing a lot of very deep, intense interviews with the homeless population, specifically with regards to pain. So from their perspective, yeah, pain was what led to becoming homeless. Now, can we think, and you can think in your head because I'm going to give you the answer in a moment, but can you think what kinds of issues would arise from having chronic pain that would then in turn lead to being on the streets or being in a shelter? TikTok, change. So from the same study, they began to gather information from the people who were being surveyed, and this is some of the stuff they were coming up with. So a lot of it was they couldn't work. They couldn't pay their bills. And we talk about here in the States about how close people live paycheck to paycheck, right? And it sounds like that's not too far off from other parts of the world either. So it's not like this is something that is unique to the United States. We just happen to have a system that maybe there aren't the same safety nets. There's less of a cultural identity with the idea that maybe we should be helping other people out. And that if you fall on your knees in the States, you must have done something wrong, you made a bad choice, and therefore it is your responsibility to pick yourself up. And if you can't do it, Sorry. There, I almost got that right, yeah? I'm sorry. And interestingly, though, they might not have been doing drugs before they ended up on the streets. But now, as a means to manage their pain, they have found access to things that will just kind of take it away. And then we see them in that state, and we make the assumption that they just want to be out there. They want that dollar bill or whatever it is on their cardboard sign because they need to go get drugs. Well, if you don't have access to care and you have to get your own care, you might have to pay for it. So I love this term now because it's so descriptive of what goes on. Rough sleeping. That came out of the Groundswell Project in a reference to sleeping on the streets, under bridges, on park benches, and imagine what that'd feel like. I mean, my bum gets tired of sitting in these chairs. They're not horrible chairs. I mean, if anyone wants to be assessing them for ergonomics, you can have that conversation at lunch in the bar. But imagine if you had a concrete sidewalk or doorway, and that was your bed. How would you feel in the morning? And then how would you feel about moving from that spot to find another spot to do the exact same thing for the next night? At what point would you begin to feel like this life was just shit? So examples of rough sleeping. This is Stockton. This is a little tent campus being formed about 12 miles from where I live. This was on the pier in Ocean Beach. I don't know how well you see it. If you have like your little app access, here's a gent sitting on a park bench. He's got a little cart. He's got all the stuff in there, sleeping bag, all of that stuff. So my guess is when it gets dark, he's either going to find a spot nearby or he's got maybe a spot set aside somewhere else. I want you to take a moment to read that because I can't do it justice. You heard some folks with Joe and Keith earlier, and this is from someone who's got pain issues, life on the streets. So here I'll say, at what point do we decide that maybe a biomedical model is really not the model that is going to do much to help this particular person find some different direction for their life? Oh, my title. You get about halfway through, and here we are. I've seen a lot of really good academic descriptions about what living with uncertainty means. And as Ben has said, and a few others, oh, I don't have a red card, Eric, but this is going to be my red card, okay? This is purely my opinion. What I take from living with uncertainty is I can go home, and I am fairly certain when I go home, my family's going to be there, my dog's going to be there, my bed's going to be there. And I'm fairly certain that when I go to bed at night and whatever sleep I get and wake up in the morning, they're going to be there as well. I'm going to go to work, and I'm going to have a job, and I'll go through all that stuff, and I'll repeat that cycle over and over again. There's a little bit of predictive processing here maybe, right? So when that's no longer possible, what does that do for our sense of safety and security? What kind of behaviors are we going to do that may not be, from my perspective, all that helpful in trying to figure out how do you have less pain? Or how do you figure out how to do something functional when your whole function is just picking up your stuff and finding somewhere else to stay for the day and the night? This lady here I know you can't, that's a tent. But the lady that lives in this tent, this is across the street from our downtown clinic. And so we are kind of in the thick of it. So I heard this psychologist, Wendy Wood, who's down actually, I guess, up at USC, and started talking about habits. And yesterday morning, I think it was, Sandy, we had this conversation about habits. And there's a lot of things that we do automatically, and we don't realize that we're doing them. Her assessment from some of her studies is that it's somewhere between 40 and 50% of what we do every day is just habit in the same context. And if we don't change that context, we're probably not going to assume that habit's going to change that much. So I came up with this little infographic. Hopefully it comes out well, because I was just like a last minute throw in there. And I realized that for a lot of us, it's kind of like the old iceberg analogy, right? It's a very popular thing out there, right? There are habits we're aware of, and there's a lot of habits that we're not. And when we're in survival mode, the unconscious habits tend to be the ones that typically be the most prominent, because we just want to get through the day. And so if part of my habit is I have to get up and I've got to walk 4 miles with a backpack weighing somewhere between 80 and 100 pounds, and I can't stop until I find somewhere else to rest my stuff safely and securely, how is it ever going to help me get to a point where I can actually say, I'm feeling a bit better? Or what, as Sandy likes to say, what would that even look like? So in our clinic, when people come in, and that was a very rough segue, by the way, but when someone comes in to the clinic for service, one of the things they all get is an automatic screening for depression. And it's through the PHQ-9. If you're not familiar with it, there are a lot of really good articles that have it in a variety of situations and what the indications are for what the scoring means. But typically, when someone scores in our clinic, if they're usually at about a 10, they'll get an automatic referral to our behavioral health counselors. And we have an amazing team that I work with to kind of integrate what they're doing and what I'm doing. We also use this. It's called the Prepare tool. And again, this may not be something you all are familiar with, but it is, when I show you how we've modified it, even though it's not technically validated what we've done, we get a much better sense of how we can actually get to some better information. And I think this graphic is really cool. So we just address basic needs. Do you have transportation issues? Work? Do you have insurance? Are you in food stress? Housing stress? And then that gives us a little bit more to work on. We have a lot of resources we can access. But again, if the provider's not going to be having the time or the intention to ask these questions, then what happens to that person when they leave that doctor visit? They go home or wherever they're going to the exact same situation that is making their life much more harder to manage. So when they come in to see me or they see a provider, I had to do this for Ben because if he was thinking it, he is now, that if there's an issue on a high score for our behavioral health folks, it might be suicide ideation, there may be self-harm, and they get immediately, our medical assistant will go contact the behavioral health and say, this person needs you right now. I do the same thing. And I've also had people come to me who are needing a little bit more advice before they go home about back pain, knee pain, shoulder pain. So in the time that I have left, which is rapidly declining because this clock is not stopping, I was reading a book for being a better parent for my son. And this was the book that our psychologist recommended. It's called The Power of Showing Up by Siegel. And if there are people here from last year. Some of these themes will seem really, really familiar to the presentation that Maxie Michuk gave to us all and her pictograph of the box, which I still think is one of the coolest things I've seen relating to building a therapeutic alliance ever. I didn't put descriptors here because this is for you to figure out. How do I, as a clinician, make my patient feel safe? Knowing now there's some things that are out there that I can't control. But I can't control the environment in the clinic. So one of the things I do to make them feel safe is I don't sit by the door. I create a spot where if they feel like they need to get up and leave, I'm not going to get in their way. But I also create a space where they don't have to feel like I'm interrogating them. I took a page from Peter O'Sullivan, and I sit lower than they are. And if they try and get lower, I get lower. As much as possible. I don't wear this, by the way. That would be kind of edgy. But I want to make sure they're seen as well. That's that validation word, right? They need to know that I'm there for them. And in the course of my interview, or when we're just talking, I do ask about their story. Some give me a very confused look because they've never been asked that question before, and they may not be ready to tell it. Some are like, oh, where do you want to start? I'm kind of like, wherever you feel is necessary. And they'll say, when I was 7, I fell out of the tree. And I'll be like, okay, I'm with you so far. But there's a lot that builds from that moment when they realize that I'm not there to tell them what to do. And now Soothe. Now again, this came from a book talking about parenting with kids. But if I replace Soothe with a word that we typically use in our areas, which is reassurance, does that now begin to feel like, oh, yeah, okay, I can do this, right? And when you have those first 3 elements together, you've now kind of made your box. And now that person can feel maybe a little bit more secure in that moment with you. This is how, by the way, I think I've figured out in some cases to get my patients to come back to me. Because the biggest challenge that I have is I can get them in the door for the first visit, but I need to make sure that they feel that I'm a safe place for them to be in order for them to feel like they want to come back. And it's not even about what I do in the interventions. It's all about that first 20 or 30 minutes where I'm letting them know I actually really want to help you. And we may not figure anything out today other than that. So I'm going to quickly deviate to here as my ticker goes down, and I want to get to at least one of my patient cases. All right? And there's a couple of studies about, well, what can we do? And where's Neil? Okay, so I'm going to jump ahead real quick, though, because I need to get to, oh, there we go. So when I took Neil's class, he introduced us to the CASP tool. If you guys have taken it, you know what I'm talking about. It's a way to kind of go through research and say, this is good, this is not good. And there was a point where he said, if you've gone through these first few questions on the tool and you don't meet any of the criteria, then that goes in the bin. So when I looked up anything related to exercise or even manual therapy in the homeless population, I had a very full garbage can. There is jack shit. I did find some studies about CBT, education, versus whatever usual care is for low income. This was in Alabama, so kind of in a rural setting. And they found some interesting things that, amazingly enough, in a group setting, in group education, some folks in CBT and education did better in getting their brief pain inventory scores lower and some functional scores maybe a little better, but only briefly. Because then things kind of sort of went back up after a little bit of time. That's 6 months after the intervention ended. There was a great study that looked at introduction of yoga to low-income families individuals experiencing acute low back pain. And the intervention was 1 week or 2 weeks of yoga classes, but no control. And just kind of by a show of fingers, 1 or 2, which group do you think did better? Twos. Wow. Yeah, they did the same. And here's the thing. It's acute low back pain. And I put it in chronic low back pain. That was my bad. It's acute, actually, when I went back and looked. And 12 weeks is about how many months? About 3, right? So what do we know about the resolution of acute low back pain? About 3 months. And if it's not resolved, now it's chronic. So shockingly, that regression to the mean, right? Okay. So I do use exercise and movement with my people who are homeless. I guess I couldn't call them my people, I guess. But I want to talk briefly about one woman that I've seen for quite some time. And our first visit was for ankle pain. And she kept tripping and spraining her ankle. And I finally looked at her and I said, "What am I wearing?" And she's like, "Well, I can kind of see the color." I said, "When's the last time you saw an eye doctor?" She goes, "Well, I had glasses 2 years ago, but they were stolen." So I have an optometrist down the hall. So I go to my assistant, "Can we get her an appointment?" Now, there are a lot of other issues with her because she was one of the few that got a shelter spot. And so shelters say you have to leave by 7 in the morning and you cannot come back until 7 in the evening. So you've got 12 hours to do whatever the hell you want and don't come back until we open the doors. And so what does that mean for someone trying to deal with pain and having a place to rest? And again, in Stockton, it gets down to about freezing in the wintertime. In the summer, it'll get to 105, 110 degrees on some days. So imagine that again. What is that doing for us and our ability to kind of keep going, right? So with her, through her cycle in and out of the clinic with me, because I got her glasses taken care of, that was where she felt this was a secure place to be. We began to work on some stuff because she couldn't walk fast. She was always afraid of falling. And pretty soon, as she began to see that things were maybe getting a little bit better for her, her falling episodes began to decrease. And she felt more safe walking out with her husband to where she didn't have to hold on to his arm and that she could actually go out of the shelter in the morning and kind of do a little bit on her own. She began to feel like, I'm not happy with my situation, but at least I feel like my life is somewhat better than it was a few months ago. And maybe that's all that I do. I will skip Mr. N, even though he sounds kind of like a James Bond villain, and just kind of touch on real quick about some of the issues that were introduced to me that are some maybe viable solutions in the 2-ish minutes I got left. And that is, thanks to Deborah, she gave me this resource. The UI, University of Illinois hospital system, came up with a plan to address their homeless who are cycling in and out of the ER. And what they found was, again, shockingly, that when you gave people a place that was stable to sleep and to stay, their need for emergency medical services went down. And what my red card opinion is that what we're doing is we're normalizing them with the rest of the population. We don't take chronic pain away, but maybe what we're doing is getting it back in line with the general population. And then in my hometown, we have a brief pilot program that's looking at a universal basic income of about $500 a month for 18 months. They've randomly selected 125 families, and what we're finding is, these are families who are at risk of being on the streets, of losing their apartment or their home, and they still have a safe place to stay. And then California just went ahead and said, we're going to give you some more money, and honestly, I don't know how they're going to spend it. I have some skepticism it's going to go anywhere good, but I do want to be hopeful. So, I'm going to throw this to you, realizing that you all want to keep your appetite, right? You guys are not hungry. That is so awesome. Okay. Perfect. We can end that one real quick. Oh, yeah, it's going to happen. Don't worry. You may not want it to happen, but it's going to happen. Okay, but real quick, thank you, guys, because I'll do the twirl in the moment. The resources I put here for you guys to latch on to are where I started to start this exploration. And there's always things out there for clinicians, especially the National Healthcare for the Homeless Council has actual resources for clinicians based on the studies they are doing for a variety of health issues, including managing chronic pain.
All right, thank you very much, Jamie.
The pleasure is all yours.
It really wasn't. But, okay, well, let's do the questions, and then you can do the twirls. Okay, so the first question's from Alice Sanvito. Any thoughts on why the homeless population is so disproportionately male?
Again, I'll give you my opinion, because most of the patients that I see are men. And what I find is there's a lot of mental health issues that I find, and as well as addiction issues, whether it's alcohol, that's the main one that I see. That tends to be also the men that for the, I hate using the word breadwinners, but there's a lot of shame in our culture in, quote, a man not being able to hold their own with employment. And so very oftentimes, they're the ones that then get depression, they start drinking or getting further into their opioids, and then they're the ones that end up just walking out. They don't seek out help. They don't want to ask the questions. The women that I've worked with have been a lot more open about seeking services. They ask more questions of their doctors, but they also get completely ignored by a lot of other healthcare providers because they're being, what's the word, hysterical? What a horrible word. I'm not sure that answers the question directly, but this, from what I've seen so far, seems to be the pattern.
Okay, now a question from Robert Haddow. Thank you. This is a fantastic talk. How do you manage to maintain consistency and quality of care when you're regularly dealing with such heavy material? I personally don't know how I'd stay consistent without burning out.
This is my joke gag, just so you know. But honestly, and okay, I gotta do my horrible Ben Cormack imitation. If I'm being honest, it's hard, and I honestly don't know that I'm doing it well. I have a lot of issues that I've bounced with people who are very close to me. I've sought out advice from my mentors, Sarah and Sandy and some others, because this is something that I grapple with every day. But at the same time, I feel so driven at this point in my life to do something a little bit more impactful because I'm also attempting to be a role model for my kid. And so I think I don't do the best job of managing stress, and kind of dovetailing on Mark and Sandy's talk last year, I've moved from the high levels of burnout to a mid-level to where I think I'm beginning to feel like there's some positive movement towards me not completely falling down on this. Because I am the only physical therapist for our entire system of 18 clinics, and I'm building something that I have no idea where it's going to go, what it's going to look like in a year, let alone what it's going to look like in 6 months. So it's tough. I hear the shittiest stories that you could ever imagine wanting to hear. And I'm not going to say I'm sitting there stoic. I wish I could say, oh, well, that's interesting. I cry. I hug my patients. And sometimes that's all we do. Sorry.
All right, next from Rachel, my whistleblower. We've heard about the importance of validating the person pain experience. Is there a difference in how we validate a person's homelessness without sounding condescending?
Yes, because I can tell you I've done both. And I learn really, really quick when the person thinks I'm being condescending. It's not like they're sitting there silently. They pretty much say, I don't think you heard a word of goddamn what I'm saying. That's not at all what my problem is. I've had that throwback at me. And not having a sounding board, not having people to kind of collaborate with all the time, I'm still kind of wandering in the weeds. And this is really how I've been learning communication, through trial and error. I have had patients get up and walk out of a session because my demeanor was not something that made them feel safe and secure. I'm okay admitting that I have sucked on days, because in order for me to suck a little less, I have to acknowledge what I did that was not meaningful to that person. And so, yeah, there have been some tough nights where I laid awake thinking, how could I have asked those questions differently? What could have I done differently so that the next time that happens, I'm a little bit less of an asshole?
All right, next from Haley Spillane. Hi, I work in a FQHC as a PA in Central Valley.
Where can I do the air high fives? Somewhere across the room?
Over there.
Oh, thank you. Double.
But she works with farm workers who can't afford to take time off of work to do the PT. Do you have any resources I could look into for some basic exercises that I could start with my low-income patients who aren't able to see a PT?
Yes, I do. Right now I'm working with our health coaches that do some basic training with and education with some of our patients coming in to figure out how to move a little bit differently. And that's what I spend a lot of time doing, by the way. My approach to strategies was from Tim Beams in his class last year, where he put a pen on the floor and said, go ahead and pick that up 10 different ways. And each way has to be different. So if we think about habits, how often do we think about our go-to habits for picking something up off the ground even, or how we do a work function? So once I have them do that, and I challenge them to say, let's come up with 2 or 3 different ways of doing that feel good to you or feel safe to you. And so it doesn't take a lot, and if they feel like they have a few more options, then sometimes they feel more confident going back to that work environment to begin to get through the day with a little bit less of that stress and that pain that's going to maybe make their day at home or the next day just as much as misery that they had that first day. That kind of rambled at the end, so hopefully that made sense.
Oh, that was great. Okay, we have one from Michelle Bellamour.
Okay.
I wonder, let me get it up there. I wonder if you can speak to how trauma is addressed with the homeless population you work with. In the context of Bessel van Koch's belly, I don't know. The body keeps the score, trauma related to chronic pain.
So I don't know if this is fitting that model, because I honestly don't remember names as well as I used to, as far as even articles I've read. I mean, Ben rattles them off. I mean, it's pretty amazing to see that. I don't remember the newspaper people articles that I read, except for Nick's. But our director of behavioral health, when I first came on board at my orientation meeting, talked a lot about trauma-informed care, about how all that influences the person. And we heard a great introduction to that yesterday with Dr. Noel and her introduction to the adverse childhood events and how much of that kind of past trauma shapes how we respond to things later in life. And so getting a better understanding of that, being okay with hearing the stories and beginning to figure out what is really maybe going on that we can actually address, because as Sarah likes to remind me, there's shit we can change and there's shit we can't. So we have to first start with what we think is going to be most meaningful based on our understanding of the evidence, and then put that into a framework that will fit our patient's belief system and be a viable option for them. I don't have no idea if that answers your question, but I've got my email and stuff, so if we want to talk further on that one, I'd be more than happy to.
Awesome, all right, and that was the last question, so well done.
Wow, thank you guys so much. Whew.
Okay, so
Anyone
now,
have a fan?
I know it does get toasted. All right, so it is lunchtime now. So if you guys could please make sure you exit out these doors over here, and do take a moment to check out the vendors who kind of help make this all happen.
There we go.
That was a better twirl. But yeah, so if you could just take a stroll by, see what they're up to, and then we're going to be back at 1:50 if you want to win any of the wonderful prizes. And then we'll be starting up with Jared Hall at 2:05.